This is what happens when you wear a green shirt in front of a green screen. But we're not talking about that today. Welcome to Derm 2. Wow, I still, to this day, remember the first patient that I had with bullous pemphigoid. It's pretty visual, and once you see it, kind of like neurofibromatosis, you don't really forget it. Looking behind me, are you kind of wondering, hey, how do I tell the difference between pemphigus and bullous pemphigoid? Me too! Yes, they are both autoimmune disorders. What I won't get into in this class is the exact protein target that discriminates pemphigus from bullous pemphigoid. And understand that while their basic path and their protein targets for autoimmune response may be slightly different, their clinical presentation is actually quite similar. Depending on where you are in your studies, farm mostly, you may have already been introduced to Stevens-Johnson syndrome, a classic mucocutaneous necrotic process. My goal in talking about them is not to have you memorize drugs that cause these mucocutaneous reactions. It's to help you understand that Stevens-Johnson syndrome exists along a spectrum of severity for mucocutaneous reactions, and actually, the worst on this spectrum of severity is toxic epidermal necrosis. So just to clarify, Stevens-Johnson and TEN are not two separate and distinct pathologies. They are actually one and the same. One is just more severe than the other. The most important thing to know about your three most common forms of skin cancer are the cell of origin. And the nice thing is, it's in the name. Basal cell carcinoma originates within the basal cell of the epidermis. Just like every other cancer we have learned about, it involves mutations, DNA damage to oncogenes and tumor suppressor genes. Throw those things out of balance, and bada bing, you got cancer. So you might wonder in skin cancer, how does the DNA damage occur? Well, in skin cancer, the UV radiation from the sun is thought to be the major damager of DNA.
I like big butts and I cannot lie.
I wouldn't be earning my keep if I did not mention tanning booths as a major source of UV damage. So if basal cell carcinoma comes from the basal layer of the epidermis, can you guess the cell of origin for squamous cell carcinoma? Yes, the cell of origin for squamous cell carcinoma is a squamous epithelial cell. Same idea, oncogenes, tumor suppressor genes, thrown out of balance, same risk factors, sun thought to be the most potent DNA damage there is, and where else is there more damage than in a
Concentrated tanning bed.
Now, basal squamous cell carcinoma, more popular, but less deadly. Then there's malignant melanoma. Its name just sounds nefarious, doesn't it? Malignant melanomas Cell of origin is a melanocyte. The cells in our skin that produce the pigment that we all have. They too can sustain DNA damage from ultraviolet radiation, either from the sun or tanning beds. And take a look at the clinical presentation pictures that I show you here. Also compare them to the clinical presentation pictures that I gave you for both basal and squamous cell carcinoma. Some of the key features are the irregularity of the borders. They lack this kind of uniform round shape. And that's kind of a gross representation of what's going on at a more microscopic level with very dissymmetric, disorganized cell growth and reproduction. Because skin cancer is so pervasive, it just bears talking about clinical presentation a little bit, especially for those of you that are going to go work in primary care. You are invariably going to have folks come in and go, "What do you think this is?" Okay, maybe not in that voice, but you know what I'm saying. ABCDE is a very popular kind of assessment mnemonic for lesions on the skin that are perhaps worrisome for skin cancer lesions. A is for asymmetric, B is for border or border irregularity, C is for color, even color versus color that changes throughout the lesion, D is for diameter or how large the lesion is, and E is a critical one, and it's the one that your patients will inform you about, and that is evolving or evolution. How has the lesion changed over time? Vitiligo is a disease of unknown pathophysiology, which really should make the whole basic path of it kind of easy for our class, right? So for vitiligo, really all I ever say is it is a condition whereby melanocyte function is lost, often what's thought to be through the destruction of skin melanocytes in certain parts of the body. Why certain parts and not others is definitely unclear. And when you work with patients who have vitiligo, you'll see a million different distributions. One thing to be clear about, this is not a condition that is limited to people with darker skin tones. My grandfather had very significant vitiligo on both upper limbs and had to wear thick sunscreen or he would severely burn. This is quite a dangerous condition when you think of the intensity of the sun and the potential for skin damage. The fact that it's associated with autoimmune diseases is particularly interesting because it does suggest that while the process may not be necessarily autoimmune in particular, it likely has some immunodysfunction capacity to it. And as we know, autoimmune disease occupies kind of one section of the immunodysfunction pie, so to speak. HIV is an immunodysfunctional disease. It's not, however, an autoimmune disease. Got a red, happy face? In middle age? Maybe it's rosacea. Though this is probably another immune-mediated condition, it looks not all that dissimilar to acne vulgaris that a lot of us, myself included, suffered from in our teenage years. Rosacea can have different degrees of severity in different people. When people get a red bulbous nose that used to be associated with alcoholism, that condition is called rhinophima. Rhino means nose. And basically, rhinophima is basically thought to be rosacea that's kind of limited to the nasal area. Eczema, or atopic dermatitis. There's a good chance that some of you watching this right now suffered from eczema as a child. There's a good chance that some of you still have some degree of eczema even later in life. The basic path of eczema is not well understood. As with most other things, you throw out the idea of genetically susceptible individuals within the right environment, then coalesce to form the pathologic condition, in this case, eczema. There's kind of two competing theories with regard to how this reddish rash condition develops. The outside-in hypothesis describes skin microbiome, the normal flora on the skin, becoming altered in some way that then hypersensitizes skin and creates the red erythematous look that is eczema. The inside-out hypothesis suggests that some immune dysfunction within the body then generates the dermatitis response that we know clinically as eczema. The interesting thing about the inside-out hypothesis is that many people who suffer with eczema come from families where immunodysfunction is common, such as families with asthma or families who have a high degree of seasonal allergies and hay fever and things of that nature. Candida albicans is the fungal organism that is infamous for causing thrush or oropharyngeal candidiasis in the mucous membrane of the mouth, producing a whitish coating on the tongue. That's not the only site where this fungus can cause problems. Moist, dark folds of the skin can also be a place where the candida fungi can seek refuge, proliferate, and cause a fairly distinctive rash that's a solid red in the center and then kind of separates into more pinpoint reddish lesions around the perimeter. Clinically, once you've seen this a couple times, you'll be able to visually identify it pretty quickly.